Let's go. This is Jason Goodwin. I'm going to take you through our med-surg nursing, first semester, chapter 54, coordinating care for patients with musculoskeletal trauma. Now, we're tapping back into what we are continuing to go through. So let's get started. So 60 to 77% of unintentional injuries reported in the US are due to musculoskeletal trauma, most of those. I have a friend that's a sports medicine doc, and that's what he tells me, that this is the most common report to the doctor. Mostly sports injuries or motor vehicle accidents, or maybe occupational injuries, maybe recreational. Around here, there's a lot of ski injuries as well in the winter. And 40% of all athletic injuries are ankle sprains. So there's an important thing to note that we talked about muscles and tendons and ligaments. You strain a muscle or tendon and you sprain a ligament, okay? We talked about this earlier, is the inversion or eversion. And so that's what you would see in a ligament, right? And the next, I'm guessing it's okay. So medical management of either one of these is in your diagnosis, you're going to do a history and physical, radiologic procedures, ultrasound, MRI. MRI is going to be the most definitive. It's not always easy to get, right? That's not the first thing they want to give you. So as far as medical management and treatment, you're going to throw in the old RICE thing, right? So first and second degree sprains includes RICE: rest, ice, compression, elevation. This is very helpful. Rest the injured extremity for up to 72 hours to allow those ligaments and tendons to heal. Ice for no longer than 30 minutes at a time, 3 to 5 times per day, for 24 to 72 hours after injury. So this promotes vasoconstriction, which will prevent the bleeding and also swelling, fluid collection, which can worsen the stiffness and the pain. Compression by, like an ACE wrap or a compression stocking can be helpful as well to keep that tightly wrapped, but not so tightly wrapped that it's going to impair any kind of circulation. And then you're going to elevate the area to minimize dependent swelling related to the position. So complications. One of the things that can be caused by this is chronically unstable joints. Could potentially cause bursitis, tendonitis, which is the ongoing irritation of a tendon, or just frequent reoccurrence, right? Like somebody that separates their shoulder continuously. Nursing management, assessing and analysis is going to be the injury to the extremity elicits swelling, bruising, deformity, and pain. We're going to look for that. If you want, looking for a nursing diagnosis, acute pain associated with physical injury, altered peripheral tissue perfusion associated with edema and vessel damage, if that's the case, and then impaired physical mobility associated with the injury. In your physical assessment, inspection is going to be very important. You're going to do a visual inspection, and then a palpation is going to be also important. You're going to be, when you palpate, you're going to be looking for the pain, the 6 P's: pain, pressure, paralysis, pallor, paresthesia, pulselessness. Okay. You're going to take a look at the movement and sensation, and then the neurovascular circulation and stuff like that. If the patient has a history of injury, you're going to want to understand that for appropriate medical management. And so it's important for us to understand the progression of whether this is a chronic injury or just an acute injury that's maybe just happened recently. All right, so we talked about RICE. I don't think there's anything else to review on that. teaching, you're going to tell them, to immediately report any worsening symptoms, which could indicate re-injury or something more serious going on. And then rice therapy is going to be best used. Now, ice is generally best used right after the injury. So some people will wait a day or two and then put ice on it. That's really too late to prevent anything. Okay, so the sooner you put that compression on there and the ice on there is the better you're going to minimize that swelling and the restriction of motion. And the other thing to know about that is just what was I going to say about that? Yeah, well, just be careful that you don't put the ice directly on your skin. Okay. All right. So as far as outcomes, optimal recovery, so you can get back to whatever you were doing and normal functioning. Pretty straightforward. Fractures. So there's a lot of fractures in this country, 6 million annually. Young and older bones are weaker. So these are more common with people with bone disorders. Cushing syndrome can cause osteoporosis, osteogenesis imperfecta, neoplasms or other cancers, anorexia, Paget's disease. Those are all things that can put you at risk for fractures. Okay, so these are the different types of fractures. So you can see a complete fracture there. You can see an incomplete fracture here where it's not completely all the way through the bone. You can see a closed fracture, which is simple and non-displaced, which means it's fractured, but it hasn't changed its position. Then you have a closed, simple, displaced fracture, right? And so that means it's sort of off-center and the damage to the tissue is a concern, right? The vasculature, because you don't want that bone moving around and potentially hurting something else. Now, if you have like some sort of depressed skull fragment, somebody gets hit in the head with a hammer, for instance, you're going to have a depressed skull fracture there. Then you have a green stick fracture. These are most common in children because their bones aren't brittle yet or rigid. So when it breaks, it breaks in completely. And that's why we call it a green stick. And then oblique just means diagonally through the bone. Open, oh boy, that's the one where you see it sticking through the skin and you want to throw up. Never had one of those, luckily, knock on wood. An avulsion, that's where something is opened up. Okay, so you can take a look at this and see. I'm just trying to see. Yeah, it's sort of like compromise and cut. Okay, and kind of filleted up, and then a comminuted fracture is one that has a lot of fragments. Compression fracture, if you jump out of an airplane and hit the ground too hard, that's what can happen with your spine. And then a spiral fracture can be done, and that's common with maybe children or domestic abuse victims where their arm is twisted. That can cause a spiral fracture. And then impacted. So if, for instance, you were in a car accident and the car came straight at your femur and compressed your femur, that's what you would have there. All right, so fractures, you got to, same thing as before. You have to understand whether it's a chronic illness or acute. They might be, your physical assessment is obviously going to be important. The history is important. And then they're going to be doing some radiologic studies, but pretty straightforward. Okay, so you're going to have either non-surgical or surgical. So if there is if it's a non-displaced closed fracture, you can do a closed reduction. So all that means is putting traction on it, and you can manipulate that and realign it. And that will sometimes be done under anesthesia if it's necessary because of the pain. The surgical repair, it's called an open reduction, internal fixation often, or external fixation. So that either means they put plates in the inside, or they actually put those in with external fixation. That's where you see the outside pins outside the leg, for instance. It looks kind of gruesome, but eventually they remove those rods. And once it's grown in, it's usually done that way when there's a lot of pieces and they don't want to anchor those to another piece of bone. All right, so like I said, this is what we call an X-fix, an external fixation, and this is skeletal traction to make sure that this bone stays in place. And so you just kind of put it on the little fulcrum there and little weight. And the same thing happens with this if you need to pull that leg, just put it right over the rail. So you'll see these sometimes in physical therapy. I think sometimes we'll bring those in, or we don't typically have to set all that up. So here's the thing about these fractures. There are complications that can happen. First of all, neurovascular compromise. So if the bone is fragmented, it can sever blood vessels or nerves. There could be venous thromboemboli. So immobility, trauma, any kind of cardiac disease. If it's a long surgery, if they're obese, if they smoke, and even if they use oral contraceptives, that can put you more at risk for thromboemboli, VTE, or deep vein thrombosis. There's a fat embolism. So long bones, when they have fractures, they have fatty bone marrow that can move into the systemic circulation, get into your vasculature, and cause essentially a blood clot, and you can die. So it's pretty serious. Traumatic rhabdomyolysis. So myelitis. So what ends up happening is there's compression of the tissue and ischemia, and that restricts the blood flow to the muscle. Myoglobin is released and spills into the circulation. And so it goes into your kidneys and clogs up your nephrons. And so you can have acute tubular nephrosis and renal failure. So what you'll end up seeing is that it's characterized by urine that looks like Coke. Okay, like a Coca-Cola. So that's something that they can treat, but it's done very carefully so that the kidneys aren't further injured. And then hypovolemia. Obviously, you can lose blood. You can lose up to a couple liters of blood in the quadricep. So you won't even know that you're losing it until you've lost quite a bit. Infection with open fractures can happen. It happens in about 1% of all surgeries. And you can have a malunion or non-union fracture. When it grows back together, it doesn't heal correctly. And that can cause deformities and also, alterations in ambulation. Okay, let's talk about an interesting one. This is called compartment syndrome. So a story, when I was in the military, I had a female Marine that came in. She was a tough lady, and she had just finished an ultra marathon, which is 100 miles over a couple of days. And she was in there for compartment syndrome. So apparently she had gone so hard and so long in this race that she developed swelling in her calf, and they ended up having to go in there, and we'll talk about what they did. They did a fasciotomy. So what ends up happening is, if you have some sort of a fracture, if you have some sort of an insult to the muscle, anything that creates bleeding or swelling, what can happen is your leg is a compartment, right? So you can look at this calf, and there's only so much place for the blood to go. So when the blood starts coming out, or whatever the tissue is, and it starts creating an increased pressure, what that can do is create a tourniquet around certain parts of your leg, and it can actually cause a situation where you can lose your leg because of compromised perfusion. So that's why we check people's feet. That's why we check their neurovascular compromise and things like that. So ultimately, you can compress the nerves and the blood vessels, and it's it's an emergent situation. So when you have this and you have a true compartment syndrome with the loss of what you think is vascularity, we're getting them to the operating room right away. And this is what we end up having to do. So in the calf, for instance, this is called a fasciotomy. So we cut on both sides of the leg, and then we cut into the fascia. Okay, and that allows that to be decompressed. It's a compartment release. Okay, and so what ends up happening is you reduce the pressure, the blood comes back to the extremity, and they end up having a pretty nasty scar on their leg, but ultimately they're not going to lose it. Okay, so we talked about a pulmonary emboli caused by fat, but let's talk about one that is caused by blood. So you can, like I said, there's multiple ways to do this, but the bottom line is you get a blood clot somewhere, and it travels to one of the in one of the greater vessels of the heart and in the lungs, and so it lodges in a major vessel, so that there can't be adequate blood flow coming through there, and ultimately what you die from is a lack of circulation, and that embolus travels up to a place that it lodges itself in the heart and or the lungs. Now the same thing can happen in the pelvis. The pelvis is a highly vascular area, so if you have a fracture site, there can be extensive blood loss there as well. So you have to keep that in mind. In fact, a hip fracture, you know, when they have what they call a stable fracture and an unstable fracture. So a stable fracture is when you have a fracture on one side of the hip, right? And or maybe it's still attached, but it's fractured. An unstable fracture is when you have both sides fractured and they're disattached. And the reason that's dangerous is because any kind of shifting in that patient's hip could create shear and could damage any of the nerves or vessels there. There's lots of nerves and vessels there. So that's a very that's a situation where you have to be very careful, and they're not going to want the patient to move at all. All right, so what do? Our assessment will tell us what the extent of injury is based on the manifestations and the medical history. Our nursing diagnoses are going to be around acute pain, muscle spasms, and trauma potentially. They're going to have an activity intolerance, obviously, impaired mobility associated with limb immobilization, and finally, impaired skin integrity potentially if there's an open fracture or if there's a cast or splints or traction, that can all cause skin integrity changes. Nursing interventions, same as always. We're going to take vital signs. We're looking for signs of pain, or our physical assessment is going to be particularly important. Looking for hemorrhage or things like compartment syndrome or infection or permanent loss of function, right? And vascular and neurological compromise. You're going to make sure the positioning is in the right place. If they have traction, want to make sure that it's effective. We want to make sure that they are resting in a place that's appropriate for their injury, right? If they have a hip fracture, you don't want their hips to be laying with the legs turned outward, right? You don't want to put pressure on the hips. So that's going to be something you're watching. We're going to take labs. We're going to keep an eye on that urine for what we talked about before, that rhabdomyolysis. And then we're going to watch the intake and output for the same reason. We want to make sure those kidneys are doing a good job. Okay. Okay, so as far as our interventions, we're going to make sure that we maintain pulmonary hygiene. What that means is you're just going to be using an incentive spirometer, deep breathing and coughing to make sure that since they're in bed, they're maintaining good alveolar gas exchange. And we're going to make sure their pain is well controlled. And any other medications they're on, we're going to administer those as well. If there are any wounds or pin care, we're going to be really diligent about that. If they have elevation, ice, or repositioning necessary, we're going to be all adherent to that. Any range of motion exercises or even just hydration, nutrition, positive feedback, encouragement, those are all of the things we're going to apply like we always do. And that will hopefully get them back on the horse. When we're teaching them, we're going to talk to them about what they can expect with the treatment. I'm going to go over what the healing process will look like. Tell them that they need to have adequate nutrition and consume lots of calories. Make sure that if they're on an opioid, they understand the appropriate use of analgesia. And then even just, taking their other medications by their prescription. How to take care of a wound themselves. Well, most of the post-op infections are caused by a bacteria that is present on the patient's skin. So is already colonized. So they actually contribute to a lot of the infections post-operatively. So make sure they know that. Make sure they shouldn't be opening it up to show everybody, right? They just want to keep that closed for whatever it's going to be 7 days before they can shower. Exercise and ambulation. We're going to make sure they're very clear on what they can and cannot do and when. If they have slings, splints, casts, or traction, we're going to make sure that's taken care of. And we're going to make sure that they're taking self-care. Evaluating care and outcomes. We want them free from infection. We want them as pain-free as possible. Prevent neurovascular compromise. And, understanding that they have nutrition and activity and exercise protocols that are that we connect them to how important they are. And then that they have, stable vital signs and normal functioning. What can happen? Oh, so we're talking about amputations here. So here are some complications of that. So in a traumatic amputation, something just spontaneously gets cut off. That can be a problem because there's complete destruction of the blood vessels and all the structures, right? So that can cause hypoperfusion. So your body essentially turns on the alarm and starts shooting everything into that area because it's worried about hypovolemic shock. So that can actually cause an increase in pressure to that wound, and that has to be very carefully pressurized. So that whether that's from a tourniquet or a compression wrap or whatever, that needs to be preventing that blood from being lost. Infection. Once you cut something open like that, it's open and it's going to be very difficult. When I was in Iraq one time in the middle of the war, it was a really bad day for a battle, and we were in a tent hospital pretty close to the front line where the Marines were fighting, and there were a lot of civilians too that we ran across, and many of them were trying to get away from the conflict, and they would be hit trying to pass a military convoy or through a firefight. And I saw a woman come in with her husband and kids, and it was a really sad situation. She had lost her foot, and they had been walking for 2 days, and she'd been walking on it, just trying to get help. And so they came in, we took care of them, but that amputation had been walking on the ground for 2 days, and it was really the human misery was really intense that day. Anyway, so hemorrhage can be a major situation. Infection can be serious, including osteomyelitis. Contractures. So sometimes what you can see is in lower extremity amputations, the lack of movement and exercise in the limb can be because they stop using it in a traditional fashion. So their knee, for instance, might be cut below the knee, but because they don't use that knee anymore, it can atrophy or see a decrease in range of motion. And then there is something called a phantom limb pain. So it's a complication where you can still have numbness, tingling, and a sharp burning pain manifesting in the area of the removed limb. It's real, and it can be severe. Supposedly weakens over time, but it can also be exacerbated. And that could be related to things like fibromyalgia, the same kind of processes, or complex regional pain syndrome. If you don't know what that is, look it up. Neuromas are clumps of nerves in the distal end of a limb that have regenerated. Sometimes those can occur in amputations, but they can develop in the limb. And what ends up happening is it interferes with proper fit or use of prosthetic devices. So it might even require another surgery to remove some of that excess tissue. Nursing management of these, oftentimes when you have a traumatic amputation, you're talking about a polytrauma, right? There's extensive damages to all of these structures. So, um, the blood loss, the signs of shock, the hypotension, the tachycardia, the pain, these can all cause life-threatening issues with the airway and breathing. So the patients can often be, significantly in pain and stuff like that. So it's a real serious situation. The nursing management. So what we're going to be looking at is acute pain associated with surgery and phantom limb pain, chronic pain associated with surgery, ineffective tissue perfusion associated with edema, impaired skin integrity associated with delayed healing and prosthesis rubbing, ineffective coping associated with change in body image, lots of different stuff, right? At risk for infection associated with invasive surgery, at risk for fluid volume deficit associated with surgical disruption of hemostasis. All of those things could be used. Nursing interventions, same as always, your vital signs, your pain, you're looking at infections. So you're going to look at the wound. You're going to be taking a look for hemorrhage. So your labs are going to be important. Those are all things that you're going to be taking a look at. Interventions. So we're going to want to make sure that we have a large bore IV line in there. Why is that? Because we need to be able to pump a lot of fluid in there if we need to, right? So we want to have that ready. We may need blood products. So we can do that through the IV as well. We may need anesthesia if the pain or the the surgery that's necessary is going to require you to be out. We may use alternative pain like regional anesthesia or even TENS units, which are the neurostimulators. So we're not going to put a pillow under the remaining portion of the lower extremity because you don't want that to develop a flexion, and that can occur if the pillow is left under the extremity. So just know that. We're going to apply ice, but not for longer than 15 to 20 minutes. It will decrease painful edema, and it also promotes vasoconstriction. So it does the right things. We just don't want to overdo it. Nutrition is going to be important because the increasing of metabolic demands of healing, you're going to need lots of protein and carbohydrates. Range of motion, you're going to be looking at strengthening the muscles pretty quickly and improving self-care. Physical therapy will be a big help in that. You're going to be applying a splint of some sort, most likely, or a prosthetic. So you want to understand how to do that correctly. Okay, so this is a procedure for wrapping a residual limb. You probably won't have to do this. And even if you will, you'll get more training. So we don't have to go into this extensively. But what you're going to do is you're going to anchor it around the waist. And then eventually you're going to go from the hip to the outer side. So what you're doing is you're anchoring it against something on the opposite side so that it will not fall off, right? And then you wrap against the opposing side. You go back up to the hip. You wrap it around, come back down, and so on and so forth, right? Pretty cool. Okay, in teaching, we're gonna same as before: medication, nutrition, and hydration. Now, here's the compression dressing and wrapping the limb. That's a whole unique situation to this, right? The wound care, signs and symptoms of infection. These are the things that they're going to be most concerned with. Range of motion exercises and community support. So when I was in high school, I had a kid that was on our team that wrestled. That he was missing a leg, and it was above the knee, and he had an amputation. It was old, and sometimes he would actually wrestle, and he would have to reinforce it because it would ooze a little bit, and that was after a long time. So that was kind of wild. But he was a great guy, and I ended up coaching him afterwards. But yeah, that was an interesting experience with an amputation. So range of motion exercises and community support. So this is a traumatic issue. It's one of those independence things, right? And so there's a lot of psychosocial stuff going on. You have to deal with that as well. Evaluating care, we want home care and rehabilitation. We want no infection, body image and physical limitation disturbances, and independence are what we're trying to accomplish. All right, so this is a little less serious, meniscus injury. So this can happen for a various amount of reasons. Maybe you have a congenital abnormality. You have some sort of chronic joint disease. You have ligament deficiencies, maybe weak quadriceps. And then, of course, anybody that is participating in sports, it can happen acutely, or it can be something that is degraded over time through repetitive stress injuries. So you have this meniscus. Okay, so the different types of meniscus problems. If you have a medial meniscus tear, that's often with excessive twisting or rotational force, and when the knee is bent, okay, or when the knee is bent. And then when you have a lateral meniscus tear, it's with sliding or subluxation. So different sports produce more likely tears, right, for the mechanism of injury. So here's what we're talking about here. Your meniscus is the padding right around here. Whoops, padding's right around here. And if you have a tear in one of those, then it ends up being bone on bone, and you don't want that. So obviously there's going to be pain. There might be swelling or fluid. And you might also see it catching or locking. You hear them explain that, and maybe some instability. So one of the things that you can do is you can do the McMurray's test, and we'll show you that in a second. The knee is supported and flexed while the lower leg is rotated internally and externally. And then the Steinman's test is when the knee is flexed and extended. So any kind of audible or palpable click or inability to extend the knee or pain is usually positive for that. But ultimately, you're going to need some radiology exams, MRI, but most likely an X-ray is going to come first. So this is the McMurray's test. You bend the knee and then you twist that a little bit. And what ends up happening is it twists the meniscus, and it helps you see when it's supported, whether that internal rotation or external rotation is creating any kind of meniscus defect. Same thing before. We're going to do the RICE and the rest, and then you might use NSAIDs to keep the swelling down. Now, the interesting thing with this is complete immobility is not recommended, because you want to keep that relatively, you don't want to completely rest it because it can cause swelling or ultimately deconditioning. So whatever the patient can tolerate, they're not going to make it worse, most likely, unless they continue with the sports. So that's when they would go in with the camera and do the arthroscopic surgery. They can get in there and they can maybe just clean it up. They can sew it back up. There's lots of things they can do. And even some stem cell therapy is being used at this point, although not fully accepted. We looked at this on another lecture, but this is what an arthroscopic surgical repair looks like. You have your shaver, which it can be used to clean it up. And then you have your arthroscopic camera, and then an irrigation cannula that goes in there. Okay. And that's how they do the work. So what are we doing? Well, we're thinking about pain. Is there a popping or clicking? That would be a positive manifestation potentially. They'd have impaired physical mobility associated with their musculoskeletal impairment, which would be a meniscus tear. Acute pain associated with musculoskeletal trauma. As far as assessment's concerned, we're going to look for inspection and palpation in that knee. Post-operatively, we're going to be watching vital signs and then also neurovascular checks. distal to the site. We're going to look at the wound site, make sure that's okay if appropriate. Any kind of drainage will be a negative finding, particularly blood or any kind of pus. And then pain, as we've talked throughout. We're going to do ice or a cold compress. We're going to elevate it. There will be range of motion exercises. We don't want atrophy or immobility. And then we're going to give pain medicine for either anti-inflammatory or analgesia. Teaching, we want them to report any change in symptoms immediately. We want them to adhere to the pain management process, make sure they're taking care of their wound, and then probably most importantly, understand what the doctor and physical therapy and rehab are going to ask them to do. Okay, carpal tunnel syndrome. So this is interesting. It's one of the most frequent compression neuropathies of the hands. And so what that ends up happening is you have swelling and compression in the tunnels of your wrist, and it ends up creating a neuropathy essentially. And we're going to go through that. So an advanced age is usually a risk factor for this. People that have repetitive motions of their hands, either musicians or computer operators, maybe factory workers that have the same repetitive job. Women are more affected than men, usually adults, because it takes some time to develop. Pregnancy can have that. Anybody with congenital malformations, someone on hormone therapy, or any kind of trauma. So what it can look like is it can decrease your grip strength, can cause muscle atrophy, and then intermittent symptoms at night, things like pain and tingling, and that has to do with compression of the nerves and tendons and ligaments. All right, they're going to have sharp pain at times, numbness, tingling in the hand, sometimes just aching. Like I said, muscle atrophy and grip strength will change. As far as the diagnosis, we're going to be understanding what the history is, what their occupation is, or maybe what might be contributing to it. We're going to do Phalen's test, which a patient relaxes their hand in a flex position for 60 seconds, and then that compresses the median nerve and the numbness and tingling. Okay. Tinal sign is when you tap the median nerve over a carpal tunnel, and they get paresthesia over the median nerve. And then they can do nerve conduction studies, EEGs, to find out what the extent of the disease is and rule out other causes. And then ultimately MRI or ultrasound can be used to confirm the diagnosis as well. The treatment is going to be trying to prevent what they are doing at work that's contributing. Ultrasound therapy or NSAIDs can be helpful, steroid injections, and then wearing a splint at night can also be helpful. If there is surgical management, it's usually an outpatient procedure, and you can do what's called a carpal tunnel release. It can be done either open or endoscopically. Complications. So what you're going to see is immobility, chronic pain, loss of sensory and motor. And then post-op, though, risks are just like any other post-op infection for this nerve injury and potentially hematoma. So you'll see an alteration in rest. Maybe their sleep patterns are disturbed because of the pain. You'll see pain associated with inflammation on the median nerve pressure, and then impaired physical mobility associated with neuromuscular impairment. What we're going to do is get an extensive history for this, work and activity history. We're going to do an assessment of the physical injury, which would include inspection, palpation, and then maybe the Phalen's or Tinal's tests if necessary. And then we are going to focus on the pain and paresthesia, which can be helpful with NSAIDs or with trying to prevent compression of the nerve. You can splint at night. You can do exercise and range of motion therapy, which prevents atrophy. NSAIDs and occupational therapy will be great for this. They're the experts. Occupational therapy takes care of the upper body. Teaching, report your symptoms, adhere to your physical therapy, follow your pain management process, and then maybe you need a work restriction potentially if it's contributing to it, just temporarily potentially. The best thing we can do for evaluating care is to make sure they're compliant with their protocol. They're getting symptom relief, and then they're trying to return to normal functioning. Okay, so Zach is a 29-year-old male who was involved in a head-on motor vehicle collision. He was the driver. He was ejected from the vehicle, and his right leg was trapped under the vehicle until the medics arrived on the scene. He was awake, alert, and yelling because of the severe pain in his right leg. On closer inspection, he had an open right femur fracture that was bleeding profusely and was missing a chunk of muscle. Wow. The EMS responders placed Zachary's right leg in a hair traction splint, started 2 large bore IV lines, and transported him to the emergency department. Zachary's breath smelled of alcohol, and his family member stated that he was at a college party. He had no medical history and not allergic to any medications. Zachary demonstrates classic symptoms of an open displaced femur fracture. The emergency department provider immediately consults with the orthopedic surgeon, and 45 minutes later, Zach is taken to the operating room. After significant irrigation of the open right femur fracture, the surgeon conducts an open reduction and placement of an external fixator. Open reduction, external fixation. Zachary is admitted to the ward for from the operating room at 6 a.m. Frequent nursing assessments are noted with the 6 Ps and performed to assess neurovascular function. Lab tests include serum myoglobin and CPK. Why is serum myoglobin? Because of rhabdomyolysis, maybe? His urine remains clear yellow, ruling out the presence of rhabdomyolysis. His pain is controlled with PO oxycodone. His provider's orders include the provision of adequate hydration and nutrition, and an order for physical therapy to evaluate his readiness for exercise and ambulation using assisting devices. If he continues to improve, he will discharge home soon. Okay, so Zach has undergone placement of an external fixator for an open displaced femur fracture. Immediately after surgery, he begins to exhibit dyspnea, pleuritic chest pain, anxiety, and tachycardia. The nurse suspects which complication? Would it be a pneumothorax, deep vein thrombosis, fat embolism, or a myocardial infarction? Well, he's a young guy. No reason he would have an MI. Probably no reason he'd have a pneumothorax either. So we're looking at one of these 2 things. Could be either one. My guess would be with the large bone fracture that it would be C, the fat embolism. And it looks like that is the case. Number 2, after the surgical procedure for an open displaced femur fracture, what actions does the nurse frequently perform? Range of motion exercises, neurovascular assessments, dressing changes, or pain assessments. Well, we're going to do all these things, probably not the dressing change right away in reality, but what we're definitely going to do is the neurovascular assessments first, right? That's the most important thing. So we have to make sure that there's no risk to life or limb, and that is what we're looking at here. And the nurse monitors for which common symptom of compartment syndrome. So you're going to look for paresthesia, pallor, pain with movement, or passive pain at rest. So paresthesia, numbness or tingling, pale, pain with movement, monitors for which common symptom of compartment syndrome. So all of these things are pretty common. The best answer is the passive pain at rest. Why? Because there's no reason you should have pain if you're not moving your calf, right? And so that indicates there's something else going on there. And an oxygen deficit in a muscle or an organ will cause pain, right? Okay, so Zachary has lost a significant amount of blood. What complication should the nurse monitor for? So bradycardia, probably not that. It probably would be tachycardia, if anything, right? Metabolic alkalosis, I don't know. Hyperkalemia, well, his potassium's not going to be higher if he's losing blood. I would say hypotension. So because of that blood loss, his body's going to be trying to compensate with that tachycardia. But ultimately, if he's hypotensive, that means that his body's having trouble doing that. And that's what we monitor for his safety. So the nurse monitors Zachary for which signs of rhabdomyolysis? Bloody urine and abdominal pain, anuria, nausea, and severe flank pain, low serum myoglobin fever and severe headaches, or elevated serum myoglobin, tea-colored urine, and severe flank pain. I'm guessing that you guys are probably already to D. Okay, tea-colored urine, that's fair enough, but I've even seen it darker than that. The point is, it looks like what could be old blood or myoglobin that's kind of changing the color of the urine. Okay, so recognizing cues. What clinical manifestation should the nurse consider when caring for a patient with a traumatic open displaced femur fracture? Well, the trauma created the bone fragments that are out of alignment, right? So often times open fractures can have more damage because of the surrounding structures and have a higher risk for complications. So there's going to be some surgery that's most likely necessary, and they're going to reposition those pieces in proper alignment. So that's what we'd be looking for. What clinical manifestations should nurse observe for when evaluating for complications? Well, certainly we're going to be looking for infection, bleeding, any kind of neurovascular compromise, blood clots or fat embolisms, and pain. What risk factors should the nurse evaluate in the patient following his open displaced femur fracture? Well, so we just talked about all of those, right? The venous thromboemboli, the fat emboli, neurovascular compromise, cardiovascular syndrome or compartment syndrome, any kind of complications with trauma, infection, bleeding, right? So you're going to be looking for pain, paresthesia, pallor, temperature, any of those types of things would indicate a problem. And then always pain is something that you should look at to see if it's indicative of something more serious as well. Okay, so what treatments are indicated for an open displaced femur fracture? All right, so it's open and it's displaced. So most likely what's happening is they're going to want to do an open reduction, right? Because it's already open. And then they're going to need to wash it out. And then they're going to do an external fixation because it's displaced, and they want to be able to anchor that outside the bone for stability. So what treatments are indicated following an OREF for an open displaced femur fracture? Well, let's see. First of all, deep breathing and coughing, incentive spirometry is going to be important. So any pain process, any anti-inflammatory medications, antibiotics are going to be part of that process, particularly since it was open. But in all cases, there's antibiotics, any surgeries. There's going to be watching for a risk of any kind of clots. Wound care and all that kind of stuff is going to be important. Let's see. Ambulation is going to be important when it's appropriate. All those things. Okay, and we finished the last slide. Here it is. What findings would demonstrate the effectiveness of the interventions? A well-managed fixation is going to be free from infection, neurovascular compromise, stable vital signs we want, INOs that are adequate, which would indicate perfusion and normal activity. So I hope you've enjoyed this. It was a long one, but it's going to be important for your career. And I'm going to be putting this on my YouTube channel for anybody else who wants to watch it. So don't forget to subscribe and make a comment below. Isn't that what they say? All right.